Good evening, and welcome to the Marian Minor Cook Athenaeum. My name is Sabrina Hartono, and I am one of your 3 Athenaeum Fellows for this year. Over the summer, I had the chance to immerse in some virtual reality gaming with a few friends back home. It feels so surreal to think that technologies that alter your perceptions of the world, albeit briefly, is actually here. Then again, there are so many innovations that push the boundaries on improving the human experience from a lot of different aspects, especially in the fields of medicine and health. But what happens when technology, in the process of healing and curing, comes with the possibility of changing you? What parts of you make you, you? How much can be added, subtracted, or changed about you that still leaves you as the same person you were before the treatment? Big questions, I know. Tonight, Professor Nolan Williams joins us to explore how novel neurotechnologies challenge our conception of who we are and how they may have a role in human evolution. Nolan Williams is an assistant professor within the Department of Psychiatry and Behavioral Sciences. Williams has a broad background in neuropsychiatry, completing residencies in both neurology and psychiatry. He has published papers in many journals, including Brain, American Journal of Psychiatry, the Proceedings of National Academy of Science, and other renowned newspapers. Aside from neuropsychiatry, his work also extends to the intersection of neurostimulation and learning. Results from his studies have gained widespread attention in journals such as Science and New England Journal of Medicine Journal Watch, as well as in the popular press, and have been featured in various news sources, including Time, Smithsonian, and Newsweek. Professor Williams is also the director of the Stanford Brain Stimulation Lab at Stanford University, which he started in 2015. The lab focuses on utilizing neurostimulation to probe the neural elements involved in control of conflict regulation within the human brain, with several active studies in the treatment for various neuropsychiatric disorders. Studies have shown that having your phone turned on while attending ATH talks are likely to interfere with your brain waves. And as such, we'd like to remind you to please turn your mobile phones onto silent mode. And we would also like to remind you that audio and visual recording is strictly prohibited. Now, please join me in welcoming Professor Nolan Williams to the Athenaeum.
Thanks for that great introduction. Make sure my phone's off. All right. Yeah, so I think I just need to log in. How's everyone doing? Great. All right, so these talks are maybe the hardest to do because I don't know where everybody's at in the scheme of things as far as try to give enough background for this to make sense, but not too much so that some of you are falling asleep in your dinner. So just if you have a question, we'll make it more active, right? So if you have a question, something doesn't make sense to you, happy to answer it during or after, okay? So I was challenged to make an interesting title, so I hope this was interesting enough. So have the following conflicts. I'm a scientific advisory board member for a type of neurostimulation that's supposed to be for enhancement of gaming and working out and things. And I also have some intellectual property in here, but I'll highlight that for you. Okay, so I'm going to give you a historical background of how to think about what we're going to be talking about tonight. And then I want to talk to you about the idea of a circuit disorder. How many of you have heard that term before? All right, so thinking about certain brain diseases being diseases of circuits in the brain. Talking about the idea that we can modulate volition, perceived control, and mood. All right, so the first idea is that neuropsychiatric diseases are all diseases of distributed brain networks. And so this is an evolving idea, right? So kind of psychiatry 1.0, a la Freud, was this idea there was something about the content. You could deal with all of this in psychotherapy. Psychiatry 2.0 is this idea that there's something about your brain chemistry, and if we just get your brain chemistry right, then you'll be feeling okay. And I would argue that psychiatry 3.0, what's emerging now is this idea that mental disorders are disorders of distributed neural networks. And the utility of that view is that Parkinson's disease is a disease of distributed neural networks. Tourette syndrome is a condition that's, neural networks have been afflicted. So this idea of neural networks being abnormal in a given condition allows us to start to kind of put certain concepts that have historically sat in neurology, which is a study of things that we understand that go wrong in the brain, and psychiatry, generally things that we don't really understand that have gone wrong in the brain, if you will. All right, so I'm going to start out with this just to give you a kind of a sense of this. So this is a guy with obsessive compulsive disorder. It's a patient of mine, so that's him. What you're seeing here in this picture before we start the video is this kind of a halo, what they call it, and you can take images. He's awake. He's had burr holes drilled into his head. He's about to get something called deep brain stimulation implanted into his brain. He is very severely obsessive compulsive, to the point where he would throw away a toothbrush every single day of his life because he was so afraid to be contaminated by it, right? And this is kind of an extreme part of the range of what obsessive compulsive disorder is. Not everybody has this level of severity, and most people, medications or psychotherapy or a combination actually help with their level of OCD, but somebody like this, more dramatic sorts of things like implanted devices end up being something that we go to, right? And this particular intervention is something that's actually approved by the FDA, by the US FDA to do in people that are this severe. So what's kind of novel and unusual about this is that lots of groups have tried to figure out if there's something they can do during the surgery to try to get a signal of what OCD is, right? We figured that we could provoke his symptoms through exposing him to this thing that he's very, kind of phobic about, right? So we brought in a sterile toothbrush, we gave it to him, his brain was pretty silent, and we then contaminated that toothbrush, right? And behind this is my neurosurgical friends. Everything's clean. In front of this, it doesn't have to be sterile. I mean, it needs to be clean, but it doesn't have to be completely sterile, right? So we gave him a contaminated toothbrush. And then what you're going to see is his brain responding to that contaminated toothbrush. The little, you can hear it almost sounds like static. That's like little groups of neurons firing in an area called the nucleus accumbens, which is the reward center of the brain. And as I'm getting this toothbrush ready for him, that's me right there, his brain is starting to fire some, right? And watch as we give it to him, what happens. You see that? The brain starts firing more frequently. Each one of those black lines is those neurons firing. And it's becoming more and more dense. That area is firing at a much higher rate than it was before, right? And what I would argue to you is that the behavior that we call OCD is what we call OCD, but what OCD is are those lines. Does that make sense? That actually what OCD is an abnormal electrical signal in the brain. And what's useful about thinking about OCD like that is that it's measurable and it's movable. We can actually stimulate something like that away. So we've known for a long time that there is a kind of a functional anatomy of the brain. Anybody know what the homunculus is? Anybody want to take a shot at saying what it is? Want to take a shot? Yeah. Yeah. Yeah, yeah. Yeah, so it's like the brain representation of the kind of amount of neurons, cortical neurons that are designated for a given function, right? And so what's consistent is that the leg part of that is always towards the middle of the brain. It's what we call the inner hemispheric fissure. So it's inside, kind of inside, in between the two hemispheres, right? And the arm down to the face kind of follows this pretty characteristic distribution, right? And so this guy, Wilder Pinfield, showed that if you're doing epilepsy surgery and this was like in the 30s and 40s, if you go through and you, with a stimulation probe, stimulate, you can actually map, right? So what I'll call this perturbation mapping is a term, and we'll talk about this later, right? And so if you can stimulate and map, if you can stimulate and get a behavior, so for instance, you stimulate the hand region, what's going to happen? Take a wild guess. It's going to move, right? Stimulate the foot region, that's going to move. What's our limitation in using a mapping tool like this? Is great, and this is necessary to understand all this. What would be the limitation? Not everybody has epilepsy, not everybody needs brain surgery, right? So it's limited by access, right? Jean Talleyrand, who's a famous functional neurosurgeon, was actually started his life as a psychiatrist, interestingly, and then became a functional neurosurgeon and learned that if you put lesions in these areas, then you can actually treat obsessive compulsive disorder. But the problem with that is you also have deficits, right? But he's the first person to inform us that there is an anatomy to mental health disorders, right? It's not just the soup in the brain with chemicals that you can change, but there's actually an anatomy to it. There's kind of a reproducible anatomy across people, right? Then this gentleman who got the Lasker Award, which is like the North American pre-Nobel, if you will, demonstrated that there are these things in the brain called frontostriatal loops. So these are circuits that are repeatable units, and some of them are designated to motion, right? Some of them are designated to emotion, right? And actually, the makeup of those circuits, whether it be motion or emotion, actually are predictable and similar, right? They all start out in a cortical area. They all affect a bunch of subcortical regions that go to an area called the thalamus, which is a relay center, and sends the signal back up to the cortex, right? So that is kind of a unit of motion and emotion, right? So this is another way of looking at it. You have this cortex that's projecting information through a decision algorithm, if you will, and that decision algorithm goes into an area that's a relay center back up to the cortex. And so what is a problem that you understand? Something like Parkinson's disease, what's going on there is that part of the circuit's broken. We won't get into why, but part of the circuit's broken. The dopamine, or the area that makes dopamine, which changes the kind of nature or properties of the circuit, is affected, is damaged, right? And so the circuit fires abnormally, and then you get this motor behavior. But the same thing seems to be true for non-motor things, for emotional things, right? In that case, or in the case of something like what we call dystonia, which is these kids that, have you ever seen these kids that are kind of pretzeled up and very twisted? Whether it be that or psychiatric problems, it's not so much that there's a loss of a given area, but that it's the electrical activity in the circuit is abnormal. Does that make sense? Okay. All right, so if there's a circuit problem, there's an abnormal electrical activity, any electrical engineers in the room want to take a wager into what you would do about a problem like that? Anybody want to take a guess? Yeah. Yeah, so that's one thing we'll talk about. So this idea that you can use a magnet to generate current in the cortex, right? But more generally, it's the idea that you can also introduce electricity into the brain, right? You can introduce electrical patterns in the brain. If the problem is electrical patterns, the solution is electrical patterns, potentially, right? So this is a cartoon of the process called deep brain stimulation. So deep brain stimulation is a invasive version of neuromodulation. It's approved for Parkinson's disease and dystonia, obsessive compulsive disorder, and tremor. Looks like a pacemaker, right? But the wires don't go into the heart. They go up, and they go deep into the brain. And where would you wager you would put a wire like that? If I said it's a circuit problem, where would you put it? In that circuit. What's that? I'm sorry? No, it's just sitting there. It could in theory, be close to your head. Yeah, no, it just sits there, but it's got a battery inside. But you would want to put it into the same circuit that was misfiring, right? And what do you think would happen if you put it into the wrong circuit? At best, nothing. At worst, you have side effects and you're not in the right spot, and we'll talk about that in a second. All right, so can anybody, you guys are going to be movement disorder neurologists for a second. Can anybody tell me what they see? Mm-hmm. That's loud. Anybody tell me what they see? What do you see? What's going on there in that scene? Yeah. So right-sided tremor, right? Okay. So what if I told you that this gentleman had bilateral deep brain stimulation implants, and then they turn the battery off on one side, right? And then he looks like this when it's off, right? Now this is what he looks like when it's on. Make sense? Okay. All right, so there are invasive ways to do this, but how many of you want to go do brain surgery next summer as a, nobody, right? It's not something that people want to do, right? So it's one of these things of most people, if they could get away with not having to do brain surgery, if they could get away with not having to be exposed to that problem, right, they would go down this non-invasive route, right? And so how do you deal with that? If you can't so could you directly electrically stimulate the brain through the scalp and skull and all of those sorts of things? You could try, and people tried, but what would you wager would be the limitation there? You can target. You can target just in the same sort of way. Yeah. There you go, smart man. So it's that you will burn skin, basically, right? Because to turn the electricity high enough, you're going to stimulate into the skin. So there's some clever folks back in the mid-'80s that got around this issue. So back to who said something about Faraday's law? Yeah, you remember what it is? Yeah, so an electromagnet pulsed will generate a current underneath it, right? So if you have a strong enough electromagnet, then you can generate a current underneath it, right? Why is that useful? Because magnetic fields do not burn you. Magnetic fields do not interact with skin or skull or scalp or any of that stuff, right? It only interacts with things that are electrically conductive. And brain tissue happens to be quite electrically conductive. So it passes through everything and then gets to brain and then it does something. Pretty cool, right? So that's the basic idea. And so this early experiment published in The Lancet in 1985, a long time ago now, I guess. He's stimulating, right? And he's moving this lady's hand. And this is the EMG. It's kind of the recording of the muscle. And you can see that the hand moved as the pulse went in. And so you can actually just move a thumb if you put it over the motor cortex region that's on the homunculus for thumb. You can move that thumb. What if you move it to the foot region? Are you going to move the thumb? No, you're going to move the foot, right? Yeah, it's pretty straightforward. All right, so let me show you a little video.
Imagine a magnetic wand that could control your brain. To find out if such a thing could actually work, I offered my own brain for a test. It seemed like fun at the time.
Hold it up, you can look at it.
Psychiatrist and neurologist Mark George said he could make my thumb twitch.
Jeez, it does. Oh, that was nice.
Using a map of the brain, he can zap the area that controls a specific body part, like my toe.
Oh, wow. Is that last stroke a little too much?
A little bit, yeah, it was a little much.
1, 2, 3, 4.
The wand can even affect someone's speech.
10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
And once the pulse is removed,
25, 26.
everything goes back to normal.
29, 30.
It's sort of a remarkable thing that one can put something over somebody's head and modify the way they behave.
Wow. The wand works by producing a powerful magnetic pulse.
So it doesn't look like a lot, but the magnetic field that it generates is about the strength of an MRI machine, of a very strong MRI machine.
Since electricity and magnetism are really just two forms of the same thing, a magnet can affect the electrical signals in your brain.
Now this is your brain. It's basically an electric web of billions of neurons wired together. When a strong magnetic pulse hits these neurons, it alters their electric current.
The process is called Transcranial Magnetic Stimulation, or TMS.
Electricity is the currency of the brain. All thoughts, all beliefs, all actions are just electrical impulses. And so TMS, we're actually able to get in there and influence the currency of the brain focally and non-invasively.
The stronger the magnetic pulse, the deeper into the brain it goes. And by adjusting the pattern of the pulse, you can change the way that part of the brain functions.
We can turn a part of the brain up or down or temporarily turn it off. It doesn't take a genius to see that it should be a pretty fertile way to begin to understand how the brain works.
All right. Now, was that helpful? Get a sense of this, yeah. So it's a simple idea, right? You stimulate with this. You do it in a pattern that the brain understands as being biologically active, and you can make something be more robust or less robust, depending upon if you're stimulating a way to turn it up or stimulating in a way to turn it down. So this is just, again, a readout of the thumb, and this is stimulation over the hand region of the brain, and you can make the activity go up in time. Does that make sense? So Mark, who's my mentor, who was on that video, in 1993, decided this kind of radical idea that you could treat depression with something like this. And why does that make any sense, right? So depression at that time was a problem of the front of the brain, the prefrontal cortex, being what we call hypometabolic, or not really using things like glucose, like, you know, not much of the food you just ate would go into that part of the brain in a depressed person, and a non-depressed person would go in there fine, right? And so if you're trying to change the activity of that area, maybe you could just stimulate it and turn it on, right? And that was the idea there. And it's the first patient, they did scans before and after, and they looked at metabolism. You'll notice that this is less bright than this is, right? And they were able to get her depression scores under control by the end of it. And this was a really radical idea. If you're a scientist and you get kicked out of a scientific meeting, you're either crazy or you're ahead of your time, right? He got kicked out of a bunch of them, right? And, you know, I think he was right. So basically, that's the idea, right? That you can turn a system online that's been offline, and you can do it in a very focal way. Why would this be interesting to people that are depressed? There's side effects from medications, right? People have side effects from these drugs that they don't like, right? Some of them, sometimes they don't work. This, other than having a very small seizure risk, something in the order of 1 on 100,000, there's no risk. There's no side effects. The other thing that this guy who showed, the second guy in the video, is that there's a laterality to this, that it's really the left dorsolateral prefrontal cortex that's involved. So, you know, you can start to get a sense of where in the brain, right? And what does that look like? That looks like the Pinfield story, right? This idea of being able to map, but this time, not have to do brain surgery to map, right? You can map non-invasively in a safe way with these sorts of magnetic stimulation techniques. So friends of mine, imagers, showed that there are these things called resting state networks in the brain. So if I tell you to get into a scanner and I tell you to have your mind wander, these certain areas will turn on consistently across everyone. You know, it's just what happens when you let your mind wander, and in the scanner we can capture this, and it's called a resting state network. These sorts of resting state networks can actually be very informative, and I was talking about this to some folks earlier. If you have a symptom that you're trying to understand that, say results from a stroke, and you want to understand where that is, you can actually superimpose all the strokes that cause that problem onto a library of these resting state scans. We have a library of 1,000 of them. And you can ask the question of how are they all connected? What's the kind of the hub point? And answer that, and you would know kind of where the center of a given problem is. So this is a problem called post-stroke hemiballismus. What that means is that your arm goes like this, you know, your arm kind of flings out. And that is the number one reason, the number one movement problem that results from stroke. And so we used to think that it came from this one spot in the brain, but a lot of times they didn't have a stroke there. But what he showed is that it's actually the network that's abnormal, right? So you can have a stroke at any point in that network, and it can cause that behavior. Does that make sense? That's the fundamental level what we're talking about. It's a network problem. No matter where in the network, if it's affected, then you have the symptom, right? So he did this same thing with depression, and he asked the question of, can we put these strokes, and then what's common? And what he found was that the left dorsolateral prefrontal cortex, which is that area that we just talked about here, right? The left, that's the area that we've been stimulating with TMS, right? We kind of understand now an anatomy of what depression is. And this shows that the amount of how long it's been going on, how bad it is correlated with the amount of abnormal connectivity in people that just have straight up non-stroke related depression, normal depression, right? It's this connectivity between these abnormal circuits. And so if you've got abnormal connectivity within circuits that are not supposed to be connected, then what's the solution for that? It's to move that connectivity, and that's what these brain stimulation techniques do, okay? So talk a little bit about this. So this is another intraoperative testing. This is a guy with tremor.
Yeah. Just hold it. Wow, he's just kind of resting it out. Bipolar again? Yeah.
So you can see he's got pretty bad tremor. And then they introduce another electrode to the brain, right? This one for his tremor.
So we're inserting the DBS electrode now. We've just finished doing the micro electrode. We're hoping that single electrode will control his tremor, but we're prepared to put in multiple electrodes.
You see, you couldn't play violin before, right? Now they're actually stimulating into the area that they're going to put the permanent lead in. And it's this idea of, you know, this talk, right? It's how does this change us, but also how does this give us the tools to go back to where we want to be, right? I mean, this guy did not ask to have this problem. He lost some level of volition, right? He lost the ability to do the things that he wants to do. And so maybe what this is the ability to give a prosthetic to return the person back to function, right? another gentleman with
It
Tourette's
is hard
syndrome.
to describe what life was like for young Jeff Madovic, diagnosed with Tourette's syndrome when he was 6 years old. There are only still pictures of the boy, who was always in motion, plagued by uncontrollable urges that led to muscle tics and got worse as he got older. Video shot by Jeff's doctor just last month capture the turmoil inside his body, wildly jerking muscles that would not be controlled with medication.
Can you do this with your right hand?
So Jeff is in no way in control of what is going on there. All those movements are not of his own volition, right? He's doing it because he's
Now your
got
left hand.
abnormal firing in the circuit that's involved
get a
in
full
movement.
body tenseness, my arm, my leg, my eyes. It could be any combination of things for any duration of time under an unbelievable amount of physical pressure.
How Jeff went from this, overwhelmed by the sudden involuntary motor tics that characterize Tourette's syndrome, to this, a man in control, calm, relaxed.
Pretty wild, right? All right, so I'll skip topics. I'll talk to you about something else we've been working on. So this idea that we can modulate cognitive control. How many of you have ever been hypnotized? Yeah? On purpose? Nice. What for? Just for fun, or? Cool. Oh, great. So in adults, which, you know, in the adult brain, which is 21 and above, which I think some of you are getting there or there, right? There's a normal distribution of hypnotizability, meaning that some people are not at all, some people are very hypnotizable, some people are somewhere in between. In kids, they're almost all hypnotizable, right? So almost all kids are hypnotizable. And so you can, one of my collaborators did a study that is kind of an edgy study published in 2000 in The Lancet, where he took 10-year-olds that had some sort of liver problem, and then they needed to get a dye procedure anyway, so that meant that they needed to have an incision in their groin area to access an artery called the femoral artery to get kind of a probe up into their liver, right? So this is a normal thing that people get when they have things like liver problems, right? So normally what you do is you give a bunch of medications that make people sleep, and they take their pain away, and then they don't remember anything, and then they got the procedure or whatever, right? And what he said is, well, we're going to hypnotize these 10-year-old kids to that normal thing, or just hypnosis. And who do you think finished sooner, had less pain and less anxiety? The hypnosis, right? The problem in adults is that it's a normal distribution, so there's only a small percentage of people that are highly hypnotizable that you know, have a bunch of benefit out of this. There's a group that most of us are kind of hypnotizable, and there's a group that are just totally not hypnotizable. And so we had this idea, this wild idea of, man, maybe we could use the TMS coil to move hypnotizability, to actually make people more suggestible transiently, with the idea that we could, there's a therapeutic benefit to that, right? Somebody needs to get their tooth pulled instead of giving them opiates, which is clearly a problem in this country. You do this, and then they act like a young kid or a high hypnotizable, pull the tooth out, the thing wears off, and you're all good, right? Something like this. And so what's interesting about hypnotizability, it's very stable. It's a trait. So, you know, if you're hypnotizable at 25, you're going to be just as hypnotizable within a range of error at 35, right? And so it's not like something you can train to do. It's not something you can really normally can really change. You either are or you aren't. It's a trait, right? But we had this idea that that trait is reflected in the brain in connectivity. So low hypnotizable folks don't have much of it. High hypnotizable folks have much more of it. And we had this stimulation approach that we knew we could change connectivity in one direction, and we knew we could change it for, you can look at this for about, you know, 130 minutes or something like this, right? So what we did is we take everybody's brain, we scan it, figure out where to put the coil, stimulate, do it again, and then we measure hypnotizability. And what we found was that when what we would have expected to be the later time point, we have a shift in how suggestible the person is. So they become transiently more suggestible. And then we looked at the brain connectivity changes, and the connectivity in the brain correlated with the change in the behavioral readout, right? So you can actually change the connectivity, and it's the amount of connectivity that changes is the same as the amount of hypnotizability that they experience transiently. So, yes, ma'am? No, they last 2 hours. So this curve right here, you normalize it about 200 minutes. Yeah, we wouldn't do that. Yeah, yeah, no, that's a great question. I mean, I was phobic that somebody would walk onto a car dealership after they did our study and buy a new car, and I'd be in the court or something having to deal with this, but that hasn't happened yet. But yeah, it's intended to be temporary, right? But what lasts 200 minutes? Your tooth getting pulled, a small surgery, that sort of thing. So it would be in that same time frame. Now, a lot of people have been very concerned about this study and the subsequent studies that we're doing. We're going to change something permanently, or what people could do with this or whatever. And it gets, so that's one whole thing, right? And then the other piece is, what does that mean, right? Like, this is a trait that people have that now we can move. Should we? What if you're high hypnotizable and you're always falling into a trance, you're always, you find that to be problematic for you? Should you be able to move that very stable human trait, right? And it's an open question. It's one that, we have no answer to yet, right? So part of this, I think I was telling these guys, part of this is that this field's kind of, it's new, so there aren't many rules. There are obviously ethical rules around doing research, but there aren't any rules about what's the right thing or not the right thing as far as trying to develop a therapeutic, right? And so these are the sorts of ethical dilemmas that we have to deal with all the time. Yeah, that was that bit. All right, so third bit. So this is a lady who got a Parkinson's implant for the tremor, right? But this was back in the 90s when we were less good at putting it in the exact right place than we are now. And this is also a French video, so she'll say a bunch of things. You won't understand her. That's because she's speaking French, unless you speak French. Oop. And so she's crying, right? What if I told you that's only when it's turned on? So if you turn it off, if it's turned off, you don't see that. If you turn it off again, you don't see that. You only see it there. What does that tell you? The emotion system can be hijacked and can be moved, and it's internal, right? There's nothing driving that sadness, and if you asked her why she's crying, she wouldn't know, right?
الديار عليكم سلام أبت أن تزل النفوس الكرام عرين العروبة بيت حرام.
For those of you that haven't been in the operating room, you're not supposed to do that. So that's what we call mania or hypomania. It's this idea of being kind of too happy, right? There is such a thing as being too happy. It's not good either. And so that was another accidental stimulation into the area that is involved with that. Here's another one. What does she look like here? Oh, kind of angry, kind of sad. How about that? What do you notice here? This is the important panel. Is there an asymmetry here? I'm going to feed you this. All right. Where's the asymmetry? Just call it out. What's that? Yeah, so the right side's a little more raised than the left side. Do you see that? Okay. So that's because her left nucleus accumbens is being stimulated.
Oh, man.
Describe what you're feeling right now.
I feel
No, she said that there, right? If you asked her there or there, what would she say? She doesn't feel happy. And she doesn't know when you're turning it on and off, right? You can't feel it. She just do this when it's on. She won't do it when it's off, right? So again, impressing upon you, emotions are generated from circuitry, and you can bypass the entire external world and move them. You could be given $1 million, like this lady 3 slides back that was crying. You could give her $1 million and then turn this on, she'd still cry. Okay? Mood disorder is a dysfunction of how the brain communicates. It makes emotions more intense, and people feel like they have little to no control, and they feel stuck. They feel stuck in this abnormal circuit, and it usually happens with other psychiatric and medical problems. So my lab studies this because it's disabling and widespread. It's prevalent. So depression and mental health disorders more generally are the most disabling condition worldwide. It's more disabling than cancer and heart disease now since 2017. And there's, because there's a lot of stigmatization, because people aren't thinking this is a real brain disorder with a circuitry embedded in it, there's less resources. There's less resources in, say, cancer, where people have thrown a lot of money. And there's a huge risk of suicide. You may know somebody in this campus or others that have had, struggled with this sort of problem. And we've really tried to tackle this novel solution bit to try to move the field forward and find new ways of treating folks. And so if these are all depressed patients, these guys are ones where normal therapies don't work, right? And medications doesn't work, psychotherapy doesn't work, and they need other things, right? And just to give you a sense of this, many, many people have this problem, and there's a lot of money that is that goes towards trying to deal with this with the therapeutics that haven't really changed in 50 years. The antidepressant drugs really, at a fundamental level, haven't changed in 50 years, and we actually go to the ones that we invented 50 years ago when the other ones don't work, right? And there's a lot of indirect and direct costs. So the direct cost is, I'm sick, I go into the hospital. The indirect cost is, I'm sick, I don't go to the hospital, I no longer go to classes here, I drop out of my classes, I have to take them, all of that kind of stuff. Or I have a job that I don't go to, right? And so there are a bunch of therapies now that are approved, right? So ECT, or the kind of electroshock therapy, which is effective, but nobody really wants to do it. I can get into that. The standard RTMS that my mentor Mark was demonstrating that is effective in about 1/3 of people, and things like ketamine that we study mechanisms of. So this is, again, what it looks like. What we're trying to do, right, is we're trying to take a brain, you see the yellow and orange? It's like where the brain's abnormally connected, right? And so this is the difference between people that are depressed and not depressed. So if you scan a bunch of people that are depressed and not depressed, the depressed people have all this stuff, all this excess connectivity. And this is what happens after you give TMS. Anybody see much in the way of any yellow? That's the difference between somebody that's responded to TMS and somebody that's not experiencing depression, not having a mood disorder, right? We can also use scans to type people and select, based off of the type of brain network abnormality they have, what treatment to use. So we've developed something called SAINT, which stands for Stanford Accelerated Intelligent Neuromodulation Therapy. We've developed a way to do this in an individual way and give a much more neuroscience-based stimulation approach. And so what that means, and folks that introduced me were talking about learning theory, what that means is that we use the brain's own ways of studying, right? How many of you have used note cards? How many note cards do you have in a note card stack usually? What's that? Too many, yeah. Take a guess. 60, 100? 50. How long does it take you to get from the first note card back to the first note card? You want to say an hour? Take the shot of that. Most people it's an hour. It's an hour, I don't know, an hour for me. Maybe you do it in 10 minutes, I don't know. But for most people, it's about an hour. You have about 50 or 60 note cards. and you get through it in about an hour. That's actually how the brain learns. We do this, we intuitively do this. We do these note cards. Why do we do these note cards? Because if you see something about every hour, then you learn it, right? Brain stimulation is a form of learning. We're sending learning signals into the brain that we have information from animal studies, recording of the hippocampus, the memory part of the brain, and we send the signal of turn on, learn how to turn on, over and over again, into brain regions that aren't on. And what we see happening, what we see in the imaging, what we see clinically happening, is that after a certain point, that person's brain is exogenously being told to learn to turn on these circuits, and then those circuits just come online, right? So that's what this idea of space learning theory is. And so you can put information into the brain using these coils, and you can put sophisticated information into the human brain, and you can do it non-invasively. And we've developed ways to do it in such a way that you can do it in the exact circuit that you want, right? And we've enhanced the dosage, so we give more stimulations, and we give it in a way that's neuroscience-based. So anybody experienced a social defeat stressor? What that is? Anybody accidentally spilled coffee on themselves or tripped over a wire in front of a bunch of people? What did you do? Your face turned red, you felt really sick to your stomach for a second, and then you kind of got over it, right? You know what happened in your brain during that time? The left dorsolateral prefrontal cortex came offline. People have studied this, right? The activity came offline, right? Depression is like, that's how everything is, right? It's like you've constantly spilled soup on your pants, right? Right? That's the feeling that these folks will describe to you. And it's because their left dorsolateral prefrontal cortex is offline and doesn't come back online for the really severe folks at all. So what TMS does by giving a neurobiologically enhanced version of this, right, and you're giving a big dose of it, is you're turning that system on over and over again, right, until it just stays on, right? That's the idea in a simplistic form, right? And so we've developed ways to, in a single person, find the best spot in the brain and use large doses of stimulation and really try to develop simple things called dose-response curves, which you may have seen in pharmacology. Okay, so we've had success with this. We've treated people all the way to people that have failed electroconvulsive therapy, and we can do this in 5 days, and 90% of people that have gotten this so far have experienced a complete resolution of their depression for variable durations. So some of this has been published, some of it's about to be published in the American Journal. But it's a dose thing, just like with any drug or anything, really. You give a dose in an appropriate way, and you can get a behavior change over time. Right? This is suicide scores pre and post. These are really high. So these are people who have like a note and stuff, and all of them went below kind of the standard clinical cutoffs. And we can see changes in the brain. So we can see changes in connectivity between that hub region of the left dorsolateral prefrontal cortex into deeper regions that regulate emotion. And those changes end up being linked up with the changes in the clinical scores. So it may be a way to actually see depression resolve. All right, so I'm going to show you one. How are we doing on time? I'm okay? Yeah, so I'm going to show you one more video, and then I'm done. All right. So this is a patient that went through. So the whole documentary is on Netflix.
I was not aware that something was wrong until I was in my early 30s. So it has been over 40 years that I've suffered with depression. And the depression started off at a lower level and got worse as the years went on. I'd say it peaked and has remained at the high level probably 25 years ago. On the scale of severity, my depression is totally debilitating. The physical pain, the mental pain, and the anguish are just maddening. You are more anxious, you're more tense, you're more nervous, you're more on edge. Then there are physical symptoms too. Continual headache, continual upset stomach, diarrhea, aches and pains in your body. And it colors your whole life. It goes through every aspect of it, and I guess I could say it'd be like having a bag over my head and wondering what the world is around me, but you can't see it because you're not able to fully interact with it.
Depression is the #1 most disabling condition in the world, per the World Health Organization. It's surpassed cancer and heart disease in the last year. About 2/3 of patients tend to respond to traditional antidepressants, about 1/3 are what we call treatment resistant. They've largely failed medications, they've largely failed psychotherapy, they're really unable to do much else. And that's generally the patient that I see.
I've probably taken 20 to 30 different types of medications, all to no effect. Either the medication didn't work at all, or the side effects were so onerous that you felt like you were dying. I've tried ECT, that didn't work. I've tried ketamine, that didn't work. I've tried various talk therapies and whatnot, and nothing has really helped.
Depression is a condition that at the brain circuit level is dysfunction in what we call the cognitive or thinking circuits and the limbic or mood regulatory circuits. There are a lot of researchers worldwide embracing transcranial magnetic stimulation. So what that is that's an electromagnet that is about the same magnetic field strength as an MRI scanner, but focused on a brain region. On the face of it, in and of itself, it's quite an effective treatment, but it doesn't capture particularly treatment-resistant patients. And so we developed a very powerful form of TMS derived directly from the same signal the brain uses itself, which is at an order of magnitude less time-consuming to apply. We can complete 7 months worth of TMS over 5 days.
After 1 week of treatment with him, my depression, for the first time basically in 40 years, went away, and it was like heaven. It was like nirvana. It was like being reborn. My senses were all amped up. It was just, the whole world was anew to me. I have had a 2nd week of treatment, and the benefits then lasted up to about 2 weeks, and I'm now looking forward to getting additional treatments.
This is applicable across levels of depression. It's applicable. Great. Just wanted you guys to hear Brandon. All right. So I think that concludes things. This is my lab. Do I take questions now? Thank you.
We now have time for questions. As usual, please raise your hand when you want to ask a question. Do stand up and try to keep your questions brief. Lala and I will approach you with the microphone, and priority goes to students.
Hi, my name is Paris. I'm a sophomore here at CMC. I was just wondering if we should be able to expect, like, in the next coming years, this to become more mainstream for depression treatment. Because I mean, I don't keep really tabs on scientific news as much as I should, but it's probably talked about more there than I would see mainstream-wise right now, because you hear a lot about antidepressants, but not that much about this.
Yeah, it's a great. So the standard form of TMS, the extended bit that takes kind of a month and a half, 2 months, it's been approved since 2008, 2009. The adoption of it is actually limited, I think, by the current physicians in the space. You know, part of this means that you have to take on a new kind of set of things to learn, you know, and it's kind of a procedural thing to do. And so I think as I train new physicians to learn how to do this all the time, and so the adoption rates of doing this increase each year. So 3 or 4 years ago, it was only 6% of people that met criteria by insurance to get it, and that's up to like 12, 18% now, something there. And the hope is that it's, you know, 90+% in 10 years. You know, that's the goal.
So these two questions kind of go together.
Yeah.
What drew you to your field of study, and what drew you to this type of treatment?
Yeah, so I was in medical school, and I was kind of confused about what I wanted to do for my life, and then I just started looking around, right, and trying to find something that made sense to me, and this really made sense to me before it was a thing, you know. So luckily I was in the same place that the guy that invented it was at, and took me as a mentee, you know, and really liked the idea of understanding these things from more of an engineering sort of way of thinking about the problem, and then the rest is history. So.
Hi there. So the use of screens is often associated with anxiety, depression. What can you tell us about how maybe these electronics affect these electric brain circuits?
The use, what was associated with?
So screen time, you know, the use of electronics does it?
Yeah, okay, yeah, absolutely. Yeah, I mean, so these electronics are obviously trying to interact in a more direct way with the brain than the way that we interact through senses. You know, you're kind of bypassing the whole sensory phenomenon to get directly into the brain, right? But it gets into this other issue of, you know, various behavioral problems that result from other technologies, right? And I think that's what you're saying. And so, you know, those sorts of problems look somewhere in between something like obsessive compulsive disorder and addiction, right? Like it seems to be like something like that, right? You're checking your phone constantly and you get some reward for checking it, you know, that's the same sort of thing. And so in theory, and people are actually doing this, you could treat those problems too with brain stimulation, right? So you could, you know, there's a study I know of now where people who are addicted to gambling, like you know, whatever, gambling in Vegas or gambling on your computer or whatever, and trying to actually reduce those symptoms through direct brain stimulation, right? But I don't see you know, there's no evidence that this stuff would increase the risk of any of that, right? So I think it enhances control, so it would reduce the risk of that. Yeah.
Hi, thank you for the talk. I had more of a systematic question on your study, which was, so you talked about how there is a curve, the neuropharmacologically speaking, there's a curve. So first of all, is there a TD, a toxic dose where it's too much brain stimulation?
Yeah, it's a great question. A lot of people were worried about that, right? So a lot of people were worried that I was going to somehow find this toxic dose of brain stimulation, right? I had some experiences with people that had implanted cortical paddles, so they'd been given stimulation for years, for a small group of people, but really, really refractory depression, where they had a paddle over the same area and was stimulating for 5 to 7 years, and they had no cognitive problems. And so there are two toxicity questions, if you will, and it's a really great question, right? The first toxicity question is there a seizure risk, right? So do you hit some point of exciting the brain and then you have a seizure? We have yet to see a seizure, right? We've stimulated close to 60 people with this protocol. I've submitted, I didn't even have to do this. I did it to be thorough. I submitted it to the FDA to evaluate it for non-significant risk, which this is a term suggesting that there is no risk, right? There's no risk more than you walking to your car tonight or driving down to your house tonight, right? And they deemed it as non-significant risk. The second one is cognitive side effects. We were really worried about that. And so we were initially sticking to people that didn't have cognitive disorders. And then we treated a few people with Parkinson's disease who we were treating because they had depression, but they also had cognitive problems. And we did cognitive testing before or after 1 month, trying to make sure we didn't miss anything. And their cognition actually improved really dramatically. And I had a student who, this was her dissertation, and she included them and then didn't include them in her analyses. And the people that had a pre-existing cognitive dysfunction, they had such a dramatic improvement that they were actually outliers, and they were driving things to be statistically significant. And you take them out, and they weren't. Some of this stuff wasn't statistically significant because the other people didn't have a cognitive problem, right? So it looks like if there is an LD50, this is your question, right? If there is a toxic dose, that comes from like mouse literature of drugs, toxic dose, we haven't gotten close to it yet, which is good news, right? So.
Hi, my name is Ajitha Anand, and I'm a sophomore at CMC. And thank you so much for your talk. It actually gave me goosebumps at some points.
Okay, cool. Thank you.
But I know this is a kind of a sensitive subject, so I want to tread lightly. But in your experience with mood disorders, at least from like the public or the media that I read, I see like a pretty wide range of statistics on like how many people have these kind of disorders and things like that. Anything from like 25 to 50 to like everyone has it. So in your experience, what would you say is like an average statistic that we can like kind of like take?
Yeah.
And in your experience and things you've done, would you say that like if the number is above 50, is a normal brain like an abnormal one actually?
Yeah, so I mean, I think that this is a great question. So I think that the statistics as a generality are about 1 in 5 people at some point in their lifetime will experience some sort of mental illness diagnosis, right? You get your kind of what's baked into your question is, so if these problems are still highly stigmatized and, people for a bunch of different reasons don't want to reach out and say they have this problem, are the numbers higher than what we think they are? I think that they probably are. I don't know if they're up to 50%, right? But I think that they're probably, more than, 20% or something. There's a study out of the University of Michigan where they take interns, so people who just finished medical school, they're like super happy, they're doctors now or whatever, and blah, 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 and they're like ready to, do some doctoring, right? And they become an intern, and then we know that a substantial portion of those folks, because of the stress of it, end up becoming depressed and anxious, right? And so they've done a good job of enrolling these guys right before med school, and now you're a doctor, so you're going to be much more likely to enroll yourself in a study like this, right? They enroll themselves, and then they get tracked, right? And as they get tracked, they get assessed. And so the rates in that subpopulation are extremely high and approach the numbers that you're talking about, right? And, it's probably not because medical school's selecting for more mentally ill people. I mean, it could be, that is not the definitive thing, and so kind of look at it and it seems kind of crazy, you have to do that much work, but I don't think that's what's going on. I think it's actually the environmental bit, right? And so, so yes, I think that the human brain is able to, under certain circumstances, experience these sorts of symptoms, right? The more realistic thing, right, is that how many of you have been sad, really sad? Raise your hand. Unless you are chronically hypomanic, you have been sad, right? How many of you have been ecstatically happy? Maybe when you got into Claremont, McKenna, right? This is what you tell your professors in here, right? So you've touched these emotions, right? The difference is that in that case, in a mood disorder case, right, mental illness is just that emotion, and it keeps going, and there's no reason. that make sense? And the brain learns to just be like that eventually, right? It's just a learning process. Brain can learn to do anything. Brain learns to just be like that, right? So the propensity to going there is there. The threshold to get there is individualized, right? But this was kind of an idea Freud had, right? All of us were kind of anxious and narcissistic, neurotic. I don't think that that's the fundamental state of what it is to be human, right? And I would argue that, some people would see this talk and they'd say, oh, wow, this is weird, and we're going to be like, doing these brain stimulation things, and we're going to be different, right? But that's not the way I see it. It's actually on the kind of the flip of it, right? Is that we know what we want to be and what our best self is, and some of these technologies can help people to make decisions to get there, right? I've never had, unlike psychiatric drugs, I've actually never had anybody who's gotten TMS, and I've given 1,000 treatment courses to people, said at the end, I feel not depressed, but I feel weird, or I feel different. I've never had anybody say that to me, not one, right? And it's really astonishing, right? And it's because I think you're bringing people back to what we would see as being like kind of true euthymia, true normal mood, And they never say, I'm not depressed anymore, but I want to go back to what I was before. I've never heard that, So I think that's, I think that's probably what normal is.
You just touched on this a bit, but I was wondering, so to your point, I'm over here, sorry. Yeah. To your point about behavior being, to your point about people not wanting to regress to a depressed state after medication, I was wondering if mood and behavior can be altered through this stimulation. If you could speak a bit about the degree to which personality is a product of the physical structure of the brain and the chemical processes there.
Yeah. So lots of people are worried. The people that are actually the most worried, end up being the most worried about this, are people that have bad obsessive compulsive disorder that are going to get treated. They really worry about this, but I think everybody does. They verbalize it more. It's this worry that somehow they're going to be different. And focal brain stimulation can't make you that different, right? Especially if we're moving the system back to where we think is normal. I think it makes you more like yourself, but there is this fear that you're somehow different. I've never had a patient, people worry about this, but I've never had a patient come to me in all of the various versions, brain stimulation modalities that I've been involved in, and said that thing, right? I'm different, I'm a different person, I don't like it, I'm not this person that I am right now. You don't hear that, So I haven't seen that. You can have side effects from misplaced leads and stuff like that make people more impulsive or something, but those are kind of few and far between now with modern methods and their technical errors. But if you're doing it the right way, you don't really see that. There's a case report I sometimes tell folks about. It was a guy who was implanted for severe OCD in that same reward center that I showed you, and he had a normal music taste. I don't know what's cool now. Jay-Z is not cool now. Whatever that is, right? He had that. I think he was German, so who knows what that was. And then he got implanted, and then he became obsessed with Johnny Cash. And he threw all of his other albums away and only listened to Johnny Cash. And then sometimes people will just miss their appointments. I don't know if you've ever done that before. Missed a doctor's appointment, right? So he missed his appointment to check on his battery, and his battery died before he got it replaced. You have to replace these batteries every couple of years. And what do you think happened? He dropped the Johnny Cash. He didn't like Johnny anymore, threw it away. They get reimplanted, and guess what happened? Came back. So that's one case in literature. Nobody else has reported that. It's a weird thing. What does that mean? I mean, if it's just that, I guess if your significant other doesn't really like Johnny Cash, that could be bad, right? But as a generality, that's the sort of thing I think we can move with focal brain stimulation. These sorts of things, maybe, on a one-off sort of scenario, but as a generality, we don't see that. We just see people feeling more like themselves.
So you've talked a lot about how this is used as a treatment to sort of return to normalcy for, from depression to, a more normal, quote-unquote, state. I was wondering if you could talk for a second about how this could be used for, enhancement or performance enhancement, which I know is probably sort of the aim of the Halo project or product.
Yeah. So I just signed like 3 days ago, something like this, a scientific advisor to those guys. And so they've got a product where they're trying to enhance cognition and performance, right? They're bringing me on to try to figure out how to, potentially get into the health space, right? So, but in a kind of like a milder way, I guess. I think that this is a big question. This is one of those hard questions, right? It's kind of the same. We have tackled this at some level with prescription stimulants, right? So there is some percentage of you that takes stimulants in this room that maybe doesn't have ADHD. There's a certain percentage of people in medical school that do this, right? And there's all these discussions about how fair this is, and the same fairness thing applies, right? So the first one is this fair, right? The problem with stimulants, that there isn't really necessarily potentially a problem with brain stimulation. Stimulants have risks, right? You take stimulants, you have a higher risk of a long list of things that all sound like a drug commercial if I rattle off up here, but it can be bad, right? With brain stimulation, those same risks don't necessarily seemingly apply, and so then the issue becomes, okay, so that's how we dealt with the stimulant issue. We're not going to deal with it like that with this issue. Is this something we should do? If it's if it does work, which is the real problem, if it does work, right? Because then there is an unfair advantage. Then what happens? Does everybody do it? Would you do it? There's this other product that's like a recreational brain stimulation device called Think. I think they went out of business, but it was around for a couple of years. But they had like this, I think what they called it is like the Rastafarian setting, and then the concentrate setting, right? And there were parties in San Francisco, it was in the Chronicle, where people would have a think party, and everybody would come in, and they'd put this thing on their head, and they would turn it on to the Rastafarian mode, whatever that means, and then they would have some sort of psychoactive-like experience. They'd all be hanging out with each other, and I never wanted to try this thing myself, just because I think it's kind of a bad idea to do that. But the idea that somebody, it had to probably work, because I can't imagine people would actually have parties with things on their head if it didn't work. I mean, could you go? Yeah. So it gets into this thing of enhancement, right? And all the problems of that, and performance, and all those problems, and then brain stimulation as a way to change the brain for recreation, right? And what do you do about that? And should we be regulating that, right? If that was a drug, we'd be trying to regulate it right now. But it's a brain stimulation technology, and nobody knows how to deal with that. So I gave a talk at the California Addiction Medicine, I think a couple of years ago, and I brought up this idea that I think people could potentially get addicted to Rastafarian mode or other devices, right? Not therapeutic devices, but devices that that people are using potentially for recreation. They didn't even know how to tackle that question I posed to the audience, right? But I think it's one that has a potential for happening, right? And we should at least be trying to figure out if it does or it doesn't. If it doesn't, that'd be great. If it does, then there may be resultant problems. So.
This will be the last question for the evening.
Great.
Hi, thanks for your talk. My name's Felipe. You said that one of your colleague that had invented TMS was getting kicked out of these meetings with all these scientists. So my question
Back in the mid-90s.
Okay, my question is, what were their criticisms
Yeah.
then? How does the scientific
Yeah.
community feel about it now? And do you see any barriers to entry for this into the mainstream market other than training physicians? Like, is it cost effective?
Yeah. So that's a great question. So just to speed forward a little bit, he runs a journal. He runs his own meeting that has like 4,000 people that go to it, and it's the largest growing field of medicine right now. And the NIH director has acknowledged these things as being the way that lots of things go, like how do we deal with the opiate crisis. So it's gone from getting kicked out of meetings to now being very mainstream. So mainstream that I'm like, I'm not usually mainstream, so I'm like, what am I doing in this, you know? But it's very mainstream now. So the idea back then was this was people that studied ECT, and they thought, so electroconvulsive therapy. So the idea that you induce a seizure and then that treats whatever problem, depression, somebody with schizophrenia. So those guys didn't think that they thought that therapeutic effect only resulted from the seizure. If you had no seizure, you had no therapy. And the goal in this is to not have a seizure, right? We try to avoid that, and it happens 1 in 100,000 times, and it's mostly operator error. So we don't want a seizure, right? And so they basically thought this was blasphemy, that you could somehow do something to the brain without, causing a seizure. That has since been demonstrated to not be true. So it took a bunch of science to show that you could actually change the brain a whole lot with things like this, where there was no seizure necessary. But that's how, if you're a student of history, like the history of science, for instance, all major paradigm shifts happen like that, right? That's the nature of science. That's the anatomy of a scientific kind of revolution or something like this, right? So he was kind of shunned for about a decade and a half, and now he's running these meetings. So. Okay.
Unfortunately, that is all the time we have this evening. Please join me once again in thanking Nolan Williams.
Thanks for having me.